Hello, good afternoon, everyone, and thank you for joining us for the Conversations webinar on living with the coronavirus vaccine. My name is Rob Reddick. I am an editor at The Conversation covering research into coronavirus. We're holding this webinar today because several COVID vaccines over the last few weeks have got very close to being approved. The drug development companies Pfizer, Moderna, and AstraZeneca have all released some preliminary data that shows that their vaccines can stop people from getting COVID-19. Medicines regulators will soon be looking at the results of the tests that these vaccines have been going through, and if they're happy with the findings, and so can confirm that the vaccines are safe and effective, then these vaccines could soon start being given to the public. This has led some people to suggest that the world could be back to normal as soon as spring. Today, we'll be discussing what we can expect as these vaccines start to be given to people. We'll look at who will get them first, how the vaccines will affect the transmission of the virus, what protection they might offer around the world, and what impact this will have on how people live their lives. To consider these questions and more, we're joined today by a panel of experts from across the UK. We welcome Dr. Sarah Caddy, a clinical research fellow in viral immunology at the University of Cambridge, whose research focuses on how antibodies protect us from different viruses. We're also joined by Dr. Michael Head, a senior research fellow in global health from the University of Southampton, who's a specialist in infectious disease epidemiology. We're also joined by Dr. Adam Kleczkowski, a professor of mathematics and statistics at the University of Strathclyde, who models the spread of infectious diseases, and also by Dr. Lynn, who's a reader in psychology at the University of Strathclyde, who researches the psychological aspects of preventing and controlling infections. If you have any questions for our panel whilst you're watching, you can put them in the comment stream, either on YouTube or Facebook, and we'll try to get to them at the end. I just want to say welcome to all of our panelists, and also welcome to everyone who is viewing wherever you are today. Let's start by looking at where we've got to in the vaccine race. Sarah, if I could bring you in first, could you tell us how close you think we are to having a vaccine approved, and when we might expect to see vaccines actually being given to people?
So I'm pleased to say I think we are a matter of weeks away from having vaccines approved in the UK. There's a number of vaccines currently under consideration by the Medicine and Healthcare Product Regulatory Agency in the UK, and these include the Oxford vaccine and also the Pfizer or BioNTech vaccine. And the media suggests that the NHS could receive the first deliveries of the Pfizer BioNTech vaccine as soon as next Monday. So that is really exciting news. And certainly medical staff across the country have been told to sort of brace themselves and get ready for the vaccine being rolled out imminently. But at the moment, we are still waiting for that final go-ahead from the regulatory bodies.
Yeah, thank you. And Adam, if you could answer this next question for us. Whilst this development has been underway, manufacturers have been working really hard to produce millions of doses, but it's clear if we're trying to vaccinate everyone in the world, we don't currently have enough to give to everyone straight away. So as these vaccines are rolled out, who will be given the vaccines first?
The vaccines, as we're coming on now, we need to start planning how to use them, and the health authorities in different countries are coming up with this hierarchy of needs. So at the top of this, are people with the highest risk of hospitalization or death, key workers, particularly in the hospital, in care homes or at hospitals, but also the key workers that support all the social and everyday life, and then followed by the general public, which the rollout would attempt to reduce the transmission in order to slow down the spread of the virus and eventually lead perhaps to the local and possibly global eradication. Different countries put those needs at different places in this hierarchy. There are differences partly due to politics and partly reflecting history of pandemic impact. So in the UK, it's largely the age ladder, with most at risk and care home workers at the top, followed by younger ages, and then health workers, followed by even younger individuals. France and Germany follows similar pattern, but that seems to prioritize more the frontline healthcare and medical, and also the key workers, the essential workers supporting the society. Interestingly, other countries go in a slightly different directions. Ecuador, which has a history of devastating outbreaks, seems to prioritize first responders, firefighters, and the key workers. Japan goes more for the old age, perhaps reflecting the fact that they do have a large proportion of the society in this category. At the other end of the spectrum, South Korea and Taiwan seem to be looking more at the long-term effects of the vaccine, and they don't seem to have immediate plans for mass vaccination. So there are commonalities as well as the individual variation across the countries.
It's really interesting to see what differences there are across the globe. And it sounds like there's various kind of high priority groups who are key to managing the functioning of society who will be prioritized in different places. Michael, if I could ask you about this, if governments are prioritizing certain individuals, is it the case that the vaccine may be mandatory for certain people or for certain activities such as travel? We've heard that the Australian airline Qantas is perhaps going to ask that everyone who flies with them takes a vaccine before they can buy a ticket in the future.
Yes, I think as much as possible, we'd like to see the vaccine to be voluntary, but perhaps in some particular high-risk groups, it could be, and I think arguably should be mandatory. So, for example, care home workers, if you are dealing with vulnerable populations, you don't want to be bringing potentially lethal respiratory infectious diseases into a care home environment. Or if you're, for example, intensive care staff, we may see mandatory vaccination in frontline healthcare workers in those sectors, perhaps. And I think it would probably be justified in terms of the populations you're working with on a daily basis. I'm sure that most of those staff will be eager to get vaccinated as well as soon as they're possible. But again, it may be mandatory. In terms of travel, we may well see some kind of proof of vaccination required to travel internationally. Again, I think we should. I think really it's a no-brainer. It's international travel, which is what spread the virus around the world in about 6 months. And also, it's not unheard of in other infections. So if you wish to go to a country that has endemic yellow fever, you will require a vaccination certificate. For the Hajj, the big festival in Saudi Arabia, about 2 million people normally go to it. And each year you do require, as part of your visa requirements, or proof that you've been vaccinated against meningitis. So proof of vaccination before travel is already a thing. It already exists. And I think where at all possible, we probably should see something similar with COVID-19.
Lynn, if it's the case that there are many activities where people are going to need a vaccine, is there going to be some pushback against kind of people feeling like they're being forced to take it? I mean, how big a problem is it that there's potential hesitancy to vaccines?
Well, there's been quite a few surveys that have been conducted in recent months that have tried to answer that question as to how many people are likely to get vaccinated once the vaccine becomes available. And the estimates vary a little bit depending on which study you look at and which country you look at. But I think we can probably expect that the majority of the population will accept a vaccine. So we're probably looking at about 70% uptake. That does still leave quite a sizable minority who are currently hesitant about receiving the vaccine. So if we look at one survey that was conducted recently by Ipsos Mori, so in October, they surveyed adults across 15 different countries, so 18,000 people in total. And they found that the uptake rate looks like it would be about 73% across the board. It looked like it would be slightly higher in the UK at 79%, maybe a bit lower in the US at 64%. So as I say, the vast majority of people would accept the vaccine. We have to point out that those surveys are looking at people's intention and that people's actual behaviour in the end might not completely marry up with what their intentions are. But it's important to think about vaccine hesitancy along a continuum. So we've got, if you think about a group of 10 people, we might have the majority, so around maybe 7 in 10, who would currently say they would accept the vaccine. We've probably got about 2 in 10 that have got concerns enough about the vaccine that it would stop them currently from accepting it, or who may be a bit kind of undecided about whether or not to accept it. And then we've also probably got about 1 in 10 people who would be quite opposed to receiving it. So it's important to note that when we're talking about vaccine hesitancy, we're not just talking about people who are anti-vaccination or who are anti-vax. We're also talking about people that may have other types of concerns about the vaccination. It's not that they're anti-vaccination. And I think it's also important to think about, are there particular groups within society that might be more likely to be hesitant than others? And again, some of the surveys would suggest that there are particular subpopulations where levels of hesitancy might be higher. And concerningly, 2 of the groups that have been noted in research are Black, Asian, minority ethnic groups, and also lower income groups, where rates of hesitancy seem to be higher. Now, we know that these groups are already at risk for more of the negative effects of COVID. So if we were to see lower vaccination uptake in those groups, we actually potentially risk amplifying even further some of the inequalities associated with COVID. So I think on the whole, we can say that the majority of people would accept the vaccination, but we do need to look at this group who are showing some signs of hesitancy, I think, to try and ensure that we get a large uptake of the vaccination once it becomes available.
And given that there are these differences between groups and also different forms of hesitancy in terms of their strength, what can be done about this? Like, are there particular measures we might expect to see governments or health authorities enacting this year or next year to try and raise rates of vaccine acceptance?
Yeah, I think the first thing we need to do is understand what people's concerns are. So the evidence so far would suggest that people's concerns largely are focused on potential side effects of the vaccine, potential safety of the vaccine, and the speed at which the vaccine has been developed. So to try and counteract that, we need to be really transparent about what the vaccine is, how it works, and also any of the kind of uncertainties around that process, including side effects. So we need to really build trust and confidence in vaccinations amongst the public. We also need to think about how we're giving that information to people as well. So for example, if we know that certain subpopulations are potentially more at risk of hesitancy, using a large one-size-fits-all mass media campaign might not really help us target all of those particular groups. So we need to think about how we're communicating with people and who is doing that communication. So for some people, those trusted sources, kind of trusted voices might be public health experts. For other people, it might be local community figures, or it might be their own GP, or it could even be a celebrity. So there could be different sources of information. So we need to think about that. We need to think about the types of messages that we're giving people. I think we need to think about emphasising the beneficial effects of vaccination for the individual, but also for their friends and their family. Another thing we need to think about is how easy will it be for people to get vaccinated, particularly when it looks like we'll need more than one dose of a vaccination. We want to make this convenient for people. We don't want there to be practical barriers that people are going to be facing to making appointments or accessing those vaccinations. So we also need to look at how we're kind of running and delivering those vaccinations. And just kind of touching on one thing that was mentioned earlier, this idea of potential mandatory vaccinations. I think from my point of view, the key really is to build trust and confidence in vaccines, not just in relation to COVID, but for vaccines across the board, so that we have higher uptake of vaccinations. And I think in some situations, mandatory vaccinations could actually undermine some of those efforts. So I think for me, it feels a little premature to be talking about mandatory vaccination when the full extent of the vaccine efficacy dosages aren't fully known yet. I think what we really need to be doing is focusing on building that transparency with the public and increasing confidence and trust in vaccination.
It feels like there's a whole world of thinking that is yet to come, and big demands that need to be met that are only just beginning. We've done the hard work of developing the vaccines, but now there's also that challenge of making sure that people feel comfortable taking them. Michael, if I could ask the next question to you. The three vaccines that I mentioned in the introduction, from Pfizer and from Moderna and AstraZeneca, they've all been developed by American and European companies. Does this mean that these areas are going to get access to vaccines ahead of others?
Well, almost certainly it is the richer countries that have put the most money into developing vaccines, and it will certainly be the richer countries that are likely to get their vaccines first, and also have the sort of healthcare infrastructure to roll out the vaccines across their own particular setting. Other parts of the world may be reliant on, for example, COVAX, which is an initiative led by Gavi, who do excellent work in kind of non-pandemic times in ensuring that vaccines are affordable for some of the poorer parts of the world, from the poorer countries. And they have set up this COVAX initiative here, where there have been pledges made that I think a few 100 million doses thus far have been sort of promised from the across the various different vaccine candidates. And they will be distributed among some of the low and middle income settings. So that will happen, but clearly it won't be enough. And I think it's inevitable that the rich countries will get first dibs and ensure that their populations get first access to them, which obviously is reasonable on the part of the sort of UK or US governments, that they look after their citizens first. But we do see that this is as I think Lynn mentioned, there's a lot of inequalities present during this pandemic, and I think that the vaccine rollout will also reflect some of those inequalities as well.
And again, going back to the idea of there being these three vaccines that are currently in the very late stages of approval, are people likely to be able to choose which of these vaccines they actually take?
People will almost certainly not be able to choose which of the vaccines they take. That'll be a decision that's made at government level typically, where governments will look at their options available, and it's going to be nice to have more than one option available to be able to choose, and choose which one is best for their setting. And factors within that decisions will include things like safety record, as has been discussed a little bit so far, and the effectiveness of the vaccine, and also the logistics of that individual candidate. So we know that the Pfizer one needs to be stored at -70 degrees, and that will create a lot of difficulties around the infrastructure around transport from the manufacturing site to the community where the vaccine needs to be administered. So it might well be that, for example, the low and middle income countries might choose if available, the Oxford candidate, which needs to be chilled rather than frozen, even if effectiveness is slightly less, which it may be from initial sort of look at the provisional results. It may still be a better vaccine for their setting, simply because it's logistically easier. So yeah, decisions will be made at sort of government or national level. It won't be much of any population choice, really.
Sarah, Michael's alluded there to the fact that there's some differences in efficacy that's been reported in these vaccines so far. I mean, what we know from the data that's been released, does it matter too much which vaccine people get? I mean, are they all essentially the same, or are there key differences between them?
So the three leading vaccines at the moment are all based on the spike protein, which is a protein that's in the sort of outer shell of the virus. And two of the vaccines, so that's the Pfizer vaccine and the Moderna vaccine, use mRNA, so a piece of genetic material that's specific for the spike. And that's delivered into our bodies using a nanoparticle. So you get injected with the mRNA, and then our own body makes the protein from this. Whereas the AstraZeneca vaccine takes the same gene, so there's still the spike protein, but it's a harmless virus that delivers this gene into our own cells. So it's an adenovirus, and in particular, it's a chimp adenovirus. So we won't have seen the virus before, and it shouldn't cause any disease. We know it doesn't cause any disease. And that delivers the gene into our cells, and then we make the spike protein. And at that point, once we've made the protein, our immune response will be the same. Should be very compatible between the vaccines. But the question of efficacy or effectiveness, we are starting to get an idea from sort of the first results from these trials. So we know that the two mRNA vaccine, so Moderna and the Pfizer vaccine, have shown really impressive levels of effectiveness. So, we're seeing sort of 95% efficacy in these trials, and these are involving roughly 40,000 people, so big numbers, and they're based on something. The Pfizer vaccine is based on 170 COVID cases, and they only found 8 cases in the vaccinated group. So really impressive efficacy data. Now, for the Oxford vaccine, we haven't got so much data available yet. The number of people in the trial has been smaller so far, but we're sort of waiting to see what extra data should hopefully be published soon. But for the Oxford vaccine or AstraZeneca vaccine, 90% efficacy was shown in one particular dose. So it was a half dose and then a full dose vaccine. But that was in 2,700 volunteers. So quite a smaller number of people compared to the BioNTech data so far. But it's going to be a case of watching this space. As the longer the vaccine trials go on, the more we're going to know, the more we're going to learn about their efficacy. But at the end of the day, it's going to come down to logistics in a big part as to which vaccine, as Michael's already said, which vaccine is delivered to which countries and as to which people, because aside from this effectiveness, there are all these other logistical details to consider, and the cost as well is worth mentioning as well. So it's not possible to directly compare them at the moment, but we're getting so much data from these trials on a weekly basis, so we'll have more information soon.
Great. And Michael, there's actually 2 vaccines, or 2 sets of vaccines we've not really considered yet that are also quite late on in their testing regimes, and that's the Sputnik vaccine from Russia, and then a couple of vaccines from China developed by CanSino and Sinopharm. What impact do you think these might have as well?
So the initial results, such as we have, that again, these vaccine candidates are in phase 3 trials, and initial results look promising. Again, certainly with the Russian candidates, there's been 1 or 2 press releases over the last couple of weeks suggesting high levels of effectiveness. We don't really know exactly what stage that is at and how trustworthy the press release results are. We need to wait and see on that. But from a global environment, I don't know, this is probably stepping a little bit into politics, so I won't go too far into it, but I wouldn't have thought the Russian or Chinese candidates will have too much of an impact on the global stage. There's a lot of westernized-led candidates in development, so I think we can expect European and North American countries to focus their efforts on them. I'd be surprised if, for example, the United States was ready to accept a vaccine from Russia at this point in time. So I think if the Russian and Chinese candidates are successful, they will certainly be used across their own populations, and they may well have great population benefit if they are pretty good. And there may be a few select other countries that buy their products. Across the globe, probably we will see other candidates, such as AstraZeneca or Pfizer or Moderna, candidates being the ones that are rolled out and more widely. That'd be my guess anyway.
Okay, thank you. So we shouldn't really be expecting to see Sputnik being rolled out in the UK, for example, at least anytime soon.
I'd be surprised, partly because there probably will be other options, and they may be more politically acceptable. They may not be simply a public health decision.
Okay, let's look ahead now to next year. Adam, as people actually begin to get vaccinated, how long do you think it will take us to see the effects? Will vaccines have an immediate impact when they start being given?
I mean, Sarah already alluded to the logistics problem. So there are 2 factors. One is the logistics of delivery, and the second one is epidemiology. So, I mean, on the logistics, we need to realize that vaccinating millions of people is a big task. Just a back of the envelope calculations, an average English general practice, doctors look after nearly 9,000 people. Counting 10 minutes per person and 2 shots, this would take more than a year of 8-hour shifts to actually go through the whole population. So we're looking at delivery of about a year. Now, obviously, there will be other additional effort put into speeding this up, but we're not looking at something that can happen overnight. The other factor is that vaccines, like Moderna vaccine, is spaced by 28 days, and the response peaked at 42 days after. So again, we're looking at not days, but months that things will start building up. On the epidemiology side, post-Christmas spike, if there is too much mixing at Christmas time, then we might be looking at another wave coming in January. Even the rollout of vaccine is not going to change much initially, because there will be just simply too much momentum in the cases. There will be too many cases coming in, and it takes a time. It might take maybe a month or two to actually go through those cases. So if vaccination starts in December or January, we might start seeing some effects in spring, depending on how fast the delivery is. But also, the other thing to mention, we've been talking about side effects, and that's clearly something that will be very closely monitored, both by health authorities and by individual people. And it might take 1-2 high-profile cases of side effects to derail or delay the program. So one thing I want to second here is Lynn's call for trust between the scientists, politicians, and the public, and they need to be very, very transparent on what's going on if we are going to actually achieve the big task of vaccination. So just to summarize that, we're not going to see effects overnight, but they will be coming if the vaccine works and the whole thing progresses well. We will start seeing things perhaps early next year, perhaps springtime.
And considering that it may take some time for these effects to kind of manifest, I mean, how do you think what we're allowed to do will possibly change in the spring? Are there activities that are not currently possible that may return sooner than others, or likewise, are there some that may not?
Yeah. Well, we already touched a bit upon this, but first thing to realize is that coronavirus vaccine, at least in a sort of short to medium term, is not a silver bullet. And therefore, there will some level of additional precautions will almost certainly need to be maintained. And perhaps we just need to learn to live both with the vaccine, as the title of our program is, but also live with the virus for a longer period of time. And indeed, the UK Prime Minister has been on record saying that the tier system can last longer than we perhaps hope it would. So the changes might come slowly. Care homes, if there is an effort going into protecting care homes, then we might see more visits, and hospitals and might return to regular treatment with health workers perhaps being vaccinated. Michael mentioned travel, and indeed airlines and countries already require vaccination certificates, and that's perhaps something that we will need to add to this, to the vaccination schedule before we travel, not only to far away places, but to places close by. Interestingly, mask wearing, might become a social habit. Some of the masks are really very impressive, and it is part of the culture in some parts of the world that people cover their faces if they're not feeling well, or if they're concerned for their health. There is this question about opening up places, but only opening them up for people who are vaccinated. And indeed, the Minister for Vaccination has recently suggested that places like restaurants, pubs, and cinemas, and sport and other venues might require a certificate of vaccination. So that's one possibility by which sort of more wider opening can be happening. But that again opens up questions of privacy and stresses the need for mutual trust and also the appreciation of concerns many of us might have for vaccine and also for the rollout procedure.
So it sounds like we may not be seeing the back of lockdowns, mask wearing, etc. just yet.
Well, maybe, some relaxation. It's a bit like, think about the first lockdown followed by summer, followed by the current lockdown. So we might be just back to the regulations that were in summer, or some version of that.
Okay. Lynn, if I could ask a question to you now. Do you think as vaccines arrive, this may have an impact on how people behave? Is there a risk that the role of the vaccine is going to make it harder to persuade people to keep up protective behaviours that we've used thus far?
Yeah, I think as Adam says, it's important that we recognise that vaccines will be one of a range of behavioural responses that we have. So the behaviour of getting the vaccine, the behaviour of wearing masks, of washing your hands, of social distancing. These range of behavioural interventions are still going to be needed, I think, for much of 2021. So I think it's important for us to think about managing people's expectations around about the vaccine and the likelihood that we will still need to enact these other behaviours, particularly as it takes time for enough of the population to be vaccinated. So I think we need to emphasise that to the public. There is I think a risk that people's motivation to engage in some of those behaviours could lessen if they have been vaccinated. So we know that one of the things that can make people more likely to adopt those protective behaviours is how at risk they feel, how susceptible they feel to the virus. So if people's levels of perceived susceptibility or perceived risk are lowered because they've been vaccinated, it could lead people to be less likely to adopt those other behaviours. So I think it's really important for the sort of public health messaging at that time to emphasise the importance of protecting other people. Even if you yourself have had the vaccine, there probably will be lots of other people who haven't. We also know that the vaccine is not 100% effective. So I think we need to manage people's expectations around about that as well. And really emphasising the fact that what we have with the vaccine is an opportunity to really drive down these levels of infections. But in tandem with that, we will still need to be performing these other behaviours that we know are also effective in reducing transmission, particularly, I think, for the first half of the year as well.
So really, they're a tool that we'll be using alongside other public health measures.
Yeah, I think we need to think about having those sort of multiple layers of protection. So none of those behaviours on their own would be, the silver bullet, the completely effective measure. But in combination, actually, we've got a really good opportunity of, I think, really driving down the rates of infection and hopefully getting us out of these damaging patterns of lockdowns. I think if we can get out of those, and if people are adopting behaviours like hand washing, face mask wearing, social distancing, those are a bit more acceptable than the more restrictive lockdown measures that we've been seeing. So hopefully we can move away from those with vaccines rollout in combination with making sure we keep up those other behaviours as well.
Okay, thank you. We've talked quite a bit here about sort of the impact of vaccines upon us. Adam, I wonder if I could turn us towards looking at what effect it's going to have on the virus itself. Over time, do you think it's possible we will reach herd immunity with these vaccines and perhaps even see the virus disappear?
Yes, you're opening up a can of worms with herd immunity concept. We'll just probably just touch just scrub the surface here. Just to give an idea of what the herd immunity is, the spread of the virus leaves some people immune, and possibly for a longer period of time, and that reduces the contacts of still healthy with infected, as the infected individuals contact the immune rather than susceptible. That leads to disease, hopefully slowing down, the disease spread slowing down, and hopefully in a long term could lead to the eradication of or demise of the virus. And the vaccination is just one way to accelerate this, and it has been very successful, remarkably successful in many diseases. The level of population immunity needed for the virus to stop spreading remains controversial. That's both to the natural immunity caused by becoming infected and due to vaccination. Some calculations show that at the top end, it's about 60–70%, which is a lot, which is a high proportion. And that's only a level that's needed to reduce the overall R number, which is the reproductive number, to 1, and which means that the infection just keeps going on and on and on for a long time. It's a bit like a permanent epidemic peak if this number is equal to 1. And to actually reach the case where the disease levels are going down, we need more immunity than this 60–70%. There are some indications that it might be lower. That could be due to the variation in response to disease. Not everybody is susceptible in the same way. And it could be because of the cross immunity from other infections. But this is we still don't know exactly how that works out. So we don't really know what those numbers are, but potentially could be quite high. Now, as we've been talking about this, it might be that the 70% uptake might be, or more, if we count in the efficacy, might be very difficult to achieve. And it's therefore very important to combine, as Lynn was saying, to combine these measures with others. Thinking about what was likely to happen in a sort of longer term, I think in a foreseeable future, we will see the epidemic behaving in a way that we saw this summer, with small outbreaks, largely controlled, but with small outbreaks, possibly caused by these super spreading events when one person infected suddenly causes an outbreak in tens or even hundreds of people. But hopefully those small outbreaks will bubble away, and if we can do both vaccination and in other ways, prevent them from merging and spreading. So that's where the herd immunity comes. It's a complicated thing, and we don't fully understand yet what exactly those values should be.
Michael, I was wondering if I could just ask you, I mean, do we have experience from other diseases as to whether we're expecting too much to reach herd immunity with this vaccine, or is it something we should still be pursuing and looking towards?
Well, I think Adam's final point in particular is important, that we don't quite know what the values are to cross that herd immunity threshold. So I might, if I may, dive into the can of worms that Adam referred to with regards to the herd immunity topic. In particular, the suggestion we should reach herd immunity is by naturally acquired infection, which was enthusiastically promoted by a few fringe scientists and one or two parts of the media, including, slightly bizarrely, Nigel Farage, who set up a political party for that specific purpose. That came from something called the Great Barrington Declaration, which is funded by slightly murky money straight out of Donald Trump's America, as well as having Nigel Farage involved in it, who is not known for his expertise in infectious disease epidemiology, I don't think. And the main problems, there's several problems with naturally acquired herd immunity with this coronavirus. If you think about the UK, we had a national lockdown when no one was moving around at all, and still then vulnerable people were not protected. We had a huge amount of excess death. So the suggestion that we could protect the vulnerable and just let the virus circulate through the population is just unfeasible. We would have so much death, we would have so much hospitalization, which would then knock on massively onto other non-COVID health services. There's a huge amount of long COVID, as it's been called, the burden from that. We know that viral pneumonia does have long-term health consequences anyway. And this particular novel coronavirus, I mean, everything about it seems to be a bit bigger and a bit badder than other respiratory viruses. So the long COVID burden will be extensive. So there's a lot of reasons as to why naturally acquired herd immunity just is not a feasible scenario in any way whatsoever. We can only really manage that with a successful vaccine, essentially. So that has to be the strategy going forward, to suppress the virus where we can and how we can right now until those vaccines are distributed around the population.
Brilliant. And Sarah, if I could ask you this next question. If vaccines are the key to suppressing the virus, is it the case that everyone needs to get vaccinated? I've seen some evidence that suggest that children, for example, aren't particularly badly affected by COVID-19? I mean, will they need to take a vaccine when they roll out?
I mean, quite simply, the more people that are vaccinated, the better. As we've already said, there's going to be a proportion of the population that won't take the vaccine or even can't take the vaccine. So individuals that are very immunosuppressed may not be suitable candidates for the vaccine. So in an ideal world, the rest of the population does have to be vaccinated. But actually how vaccines work, there's sort of two levels to what we want them to do. So firstly, we want them to stop severe disease or disease at all, so people showing symptoms. But the second level of protection is to say we don't want people to get infected with the virus. And they're two different things, because one of them is just getting illness and potentially hospitalization, and the other one is actually having any virus particles in the body at all. And what we know about the vaccines that we're hopefully going to be rolling out soon is that these can reduce disease effectively, but we don't actually know if they can stop you being infected and just not showing any symptoms. So I think there's reasonable evidence to suggest they are going to reduce transmission, but we just don't have that data yet. And that's because to get that data, you need to be testing everyone who's vaccinated on a weekly basis, and that's just not practical. So yeah, in an ideal world, the vaccine would block infection full stop. And going back to the idea about children not getting sick, well, that's been really important for children who we don't want children to be spreading the disease. Even if they're asymptomatic, transmitting to vulnerable relatives is a concern. So ideally, we want a vaccine that does stop all infections in its tracks, and we do want to be vaccinating everybody.
I mean, following on from that, should people be taking the vaccine if we know they've already had the virus, for example?
I mean, this is a great question, and to which, again, the definitive answer hasn't yet come out. The trials basically have only recruited people who did not have antibodies against COVID-19, so hadn't had the virus before. However, once the vaccine's rolled out, and there's certainly more data to be analysed from these trials, to have a look at whether having antibodies already to COVID affects your vaccine response. And there's basically two possible scenarios, really. One is if you've already got antibodies to the vaccine just might not do very much. It may be that the antibodies you already have just stop the vaccine in its tracks. So it's not going to do any harm, but it's not going to have much of an effect. But I think the more likely scenario is that the vaccine essentially is a boost to your immune response. So you've had the virus, you've got some immunity, and the vaccine comes along and acts as sort of a boost to improve your immune response even further. So I think it's going to be a great thing for everyone to be vaccinated, regardless of whether you think you may or may not have had the virus before. But again, more data will be coming shortly once more people have been studied.
And Sarah, if I could ask just one more question on the mechanics of vaccines. Those you've mentioned already, they're based on using adenoviruses or mRNA. That these are quite new technologies. Do we know anything about what their long-term effects will be? Do we know how effective they will be, months or years after they've been administered?
So, as you rightly said, the leading vaccine, so the Oxford vaccine, which uses the adenovirus vector, or the mRNA vaccines, they are technologies that haven't been licensed before, but actually they have been around for at least a decade. And so they have been studied for, a considerable length of time, but previously there just hasn't been the economic drive to push them into a licensed vaccine. So, for example, the adenovirus approach in the Oxford trial, this vaccine has been tested in about 6,000 people over the past decade, and there haven't been any major issues or any safety concerns in those 6,000 people. But I appreciate those numbers are small, but 10 years is a reasonable length of time. And similarly with the mRNA vaccines, again, they've been tested in small numbers of people in actually over 100 different clinical trials. That's been over the past sort of almost 20 years. But again, we haven't got the long-term data specifically for this vaccination in the numbers we want. But at the moment, there's no reason to think that these are going to cause long-standing problems. I mean, sort of the second question on this is to say, well, how long do we expect the vaccine-induced immune responses to protect us against COVID-2, which is a kind of another question in itself, really. And again, at this moment, we don't know. These vaccines have only been in people for 6 months maximum. But everyone in these trials is going to be followed for the next 18 months, 2 years, so we will get information. But we can make educated guesses about how long we think these vaccines are going to induce protection based on what we know from other coronaviruses. So for MERS and the first SARS virus, we know immunity was present for about 18 months to 2 years, possibly longer. So that's encouraging. That suggests the same may be said for the SARS-CoV-2 vaccines. But yes, we're basically going to be watching this space. It may be that we need annual vaccinations, but hopefully as all the vaccine companies are ramping up and more vaccines come available, that will be something that's quite feasible.
Well, fingers crossed, we see positive things coming out over the coming months and later next year. Adam, if it is the case that the effects aren't long lasting, what do you think the consequences would be on the disease?
As Sarah was saying, we don't know that. We can learn from other diseases and other viruses. MERS and SARS giving us some estimate on what the potential length could be. Well, some vaccines like measles give essentially a lifelong protection. Some need to be repeated, like tetanus. Seasonal flu is an interesting example because each year it essentially requires a new modified vaccine, which needs to be prepared in advance. And that could potentially be a bit of a hit and miss if we just get a different one to the one that will be in the circulation. So some years seasonal flu vaccine was perhaps less effective than we would like it to be. But that's something that we might, if the coronavirus follows a similar pattern, then we might need to be revaccinating the population every year or every 2 years. We might need to look into vaccinating newborn children, which is the classical way in which the vaccination and the concepts like herd immunity and critical population threshold have been introduced, and a spectacular reduction in the number of cases in a case of polio and other diseases. But we need to realize that to actually eradicate a virus, it's a difficult thing to do. It took almost 200 years to eradicate smallpox. It took perhaps 25 years also for polio, and a good part of the 20th century to eradicate rinderpest, which is the disease of livestock. And those, the smallpox and rinderpest are the only the only major diseases that have been eradicated so far. The polio is on the verge of being declared eradicated. The measles keeps coming back, partly because of the vaccine problems and vaccine hesitancy. And the 1918 flu virus is apparently still in circulation, and that, although it's a much more benign than it was then. What could happen also we simply don't know enough whether the application of an incomplete treatment, like not treating everybody, might need to rise in resistant strains. That's something that is happening with the antibiotics. So there are lots of open questions, and looking at other diseases and other viruses might help in understanding what actually might be happening long term with the coronavirus and coronavirus vaccine.
Thank you, Adam. I think, speaking of questions, we've got quite a lot that have come in from our viewers. So I think, Michael, if I could just ask you one more question, and then perhaps we can move on to those that people have been submitting. It seems like demand for vaccines is going to be quite high, and supply, at least in the initial stages of next year, isn't going to be able to meet that demand. Should we be worried about fake vaccines appearing on the market?
Well, I don't think, and I hope not anyway, but I don't think fake vaccines will be too much of a problem it certainly hasn't been a problem with other vaccines around the world, really. Not in the scale we see with counterfeit medicines, for example, which, I mean, can be a great problem in some areas. So I don't think we will see too much of an issue there. If we do require, for example, proof of vaccine to enter pubs, clubs, bars, or travel, or something like that, then there may possibly be an angle for sort of faked vaccination certificates in some way. So I think that'll be one area of concern that we need to think about when thinking about if and how we do vaccination certificates or proof of vaccination, whether it be electronic or paper-based. That's possibly an area where we may see a bit of fakery. In terms of actual vaccines themselves, I mean, remains to be seen. Everything about 2020 is new and unusual. So we shall have to see how that pans out, but my instinct, it won't be a great problem.
Okay, thank you very much, everyone. We've had lots of questions, so let's move on to some of those that have come in. I think one may appear on our screen very shortly. Yes, this is from Steve Smalt. Do we know how to recognize a super spreader, and how should they be treated? I wonder, if, Adam, if you could sort of take the lead on answering Steve's question.
Well, just to put this in account, I mean, super spreader event is a case when one or very few people can actually infect a large number and create those the super event where we get suddenly get a relatively large outbreak. And we've seen this both at the beginning of the pandemic and during the pandemic as well, when funerals, weddings, and ski holidays turned into mini or medium-sized epidemics. As we start bringing down the numbers through vaccination, then we're more likely to see those events. But it's very difficult to recognize them from their nature. They're very random and unexpected events. What we can do is, by other means, to try to suppress the possibility of creating such events. For example, there's currently a big discussion about whether ski holidays should be opened in Europe. So it's difficult to recognize them. I mean, once we see them going on, then there is a possibility of doing essentially a ring vaccination. So emergency vaccination when we try to reach people who might have been in contact with the super spreader. And that's really how the late stages of smallpox eradication were happening, where people were scanning the horizon for the outbreaks and then going in and trying to treat enough people in the surrounding areas or people who might have had contact with the disease to stop the infection from spreading further. But that is likely to become a problem once we bring the numbers down.
Michael, I think you also had some thoughts on super spreaders to say to Steve.
Yeah, I think I would essentially cover, so I agree with what Adam said just then. I just want a sort of additional point that we do sort of hear a lot, certainly here in the UK press, as to why pubs and bars are shut when there's no evidence that they are where there's much transmission in those environments. And I think the key point is this, is the super spreading events. If you can stop the super spreading events, you stop with the onward transmission, which might often occur in the home, in a household, or in an institutional environment like a care home or a hospital. So if you can stop the super spreading events at source, then you reduce those subsequent burdens of disease in higher risk areas. And we do know from the research that outbreaks start in, again, as was said, in ski resorts, in cruise ships. At the start of the pandemic, there was many outbreaks linked to cruise ships. And now that they're not happening, it is things like pubs, bars, restaurants, and so on, and gyms, where super spreading events are linked to. So that is why often the public health solution or advice is to shut environments like that in order to stop super spreading events, and which reduces the onward burden of disease.
Great, thank you very much. We have another question from Pat. Have any of the vaccine groups considered the impact of COVID-19 vaccination in pregnancy, either planned or inadvertent? Most vaccines are in fact safe in pregnancy, and I would guess that the type of vaccine might be important here, but evidence of some kind is required. Sarah, would you be interested in sort of responding to this?
I can certainly give it a go. Yes, I mean, unfortunately, the answer at the moment is we simply don't know. You know, very deliberately, the vaccine trials have excluded anyone who might be pregnant or considering getting pregnant, and I don't know of any people that have inadvertently gotten pregnant during the trials. But I would agree with Pat that, yeah, most vaccines are safe in pregnancy. Historically, there have been a few cases where a live attenuated vaccine, so an actual entire virus, can cross 1% and infect the fetus and cause problems. But none of the vaccines that we're looking at for COVID-19 at the moment are that kind of vaccine. They're all the simple spike genes and not the entire virus. So my best guess would be they are safe in pregnancy. And the benefit of vaccinating pregnant women is that the pregnant women can then pass the immunity to the fetus and then the newborn. So the newborn already has antibodies against the virus, so they're kind of born with this protective immunity already, and it's just a case of as the maternal or mother antibodies wear off, then the infant can potentially be vaccinated themselves and make their own immune response.
Great, thanks, Sarah. We have another question from Julie. Are there any plans to educate particular subgroups who are both vaccine hesitant and particularly vulnerable to the virus, e.g. low-income and BAME groups? Lynn, it'd be great to get your thoughts on this one.
Yeah, I think we do need to look at targeting particular groups. So as Julie has said, that there are these groups that look like they might be more vaccine hesitant and are also vulnerable to the virus. I think it's not just about education though. So it's not just about the sort of transmission of knowledge, although I think it's important that we think about that and tackle things like misinformation. But it's also about a sort of range of approaches and thinking about what that intervention content should be. So we need to understand what the concerns and barriers are in these groups so that we can then tailor the sort of communication accordingly. So I think going back to what I was mentioning earlier about building confidence and trust, I think that's particularly crucial in these groups. So we also need to think about the way the messages are coming across and who they're coming from. Is there a visible cultural representation? Who are the key kind of community figures that we could go to for help with these messages? So I think we need a range of approaches. So education is part of it, sort of persuasion, enablement, building of trust, building of confidence that is targeted at who these particularly kind of hesitant groups appear that they could be. Yeah, good question though, thank you.
Great, and we have another question. This is from Sean. What are long-term effects of inserting viral mRNA into host cells? Sarah, I think this is maybe your best place to cover.
Yeah, absolutely. So the key thing about mRNA is that it's really unstable. And this is why it's taken, in fact, so long to get an mRNA vaccine, because we've had to formulate ways to safely get the mRNA into host cells. So, for example, what we know is that it's only going to stick around for a couple of days maximum. Certainly with the Chaddox vaccine, so the Oxford vaccine, the adenovirus delivers the gene, and then the whole thing is gone within about 5 days. So you get that 5 days to make an immune response, but then it disappears. So the long-term effects, we don't expect there to be any real adverse effects in that regard. But again, the clinical trial teams are monitoring this very, very closely to make sure we're not seeing anything sort of down the line that's going to be a problem.
Okay, Sarah, thank you very much. This has flown by. We're nearly at the hour mark, so I think that's all we have time for. I hope everyone's enjoyed this, and I just want to say a big thank you to the panelists for their time and for the fascinating insights they've given us. So thank you very much, Sarah Caddy. Thank you very much, Lynn Williams. Thank you very much, Adam Kleczkowski, and thank you very much, Michael Head. And thank you to everyone who's been viewing this all around the world. Thank you for joining us today and for providing these excellent questions. We'll be running more webinars in the future, so Keep your eyes peeled on our social media channels for details of those as they come up. Good afternoon, everyone. Take care and goodbye.